Hello, good morning, everyone. Big hello. Okay, we have Faisal, Debian, Prajwal. Who else? Good morning to each and every one of you. All right, I hope you all are ready for the MCQs. Okay, we will have some mixed MCQs today. Okay, we also have Rishabh who has joined in. All right, so this is quick introduction. It's not going to take long about myself and about the platform that we are at. And this is Unacademy platform and myself, Dr. Rohini, and I'm an educator with the Unacademy for the subject anatomy and all these credentials you can look up. Go visit my profile. I would suggest you go visit my profile, follow me. Instead of mentioning here, you just please go to my profile, read more about myself, and see what all credentials I have got. And I also have experience outside India, and I'm also a counselor. And this is the referral code that you can use to access all my classes. So this referral code is not just for getting the 10% discount, but also to access all those free things that we offer at Unacademy, like the special classes, quizzes, tests, everything you can access. All right. Okay, so here these are some of the dedications. We have nice dedications from students who have put in so many minutes and they have earned their hats, and that is the appreciation they get for putting in so many view time. And this is what we get as educators when they want to dedicate something to us. And this is my profile. You can see the number of followers. It goes on increasing, and it has increased in the second page, you see. So every month we have lots of followers. So that means that the Unacademy is offering a very good class of curriculum, and the students are definitely benefited. Otherwise, it's mutual. So when we give you good things, obviously you will also acknowledge it, right? So these are some more things like red hat and yellow hat. All these are earned by students. And this is something interesting plus subscription. So this is what you, for this you need 10% discount. You have to use the code. So don't forget the code. Anywhere you require to use the code, please use this code. And it's my name itself, and it's not easy to forget. It's a very simple name, not easy to forget. Easily you'll not forget it. So with plus subscription, you get daily live classes, structured courses, test, quiz, and lot of unlimited access to various things. And you can also see Iconic subscription has added bonus of PrepLadder, and you also have unlimited time offers that is running. You may want to act quick, and then there is this 10% discount. Hence, the 92,000 on 36 months is reduced to just 58,500. Similarly, you have 24, 18, and 12 running, and they all have been, given with the huge 10% discount, price slashed. So this is the final amount that you would be paying when you go for the subscription. So please use the code wherever you need the discount and access to things. And this is something very interesting. Mark the date, July 10th at 8 p.m. You have this, contest, that is MedMind scholarship test, where you have the chance to get a rank between 1 and 19. So each rank would have, some benefit. Like the first one, 100% scholarship, and 2 to 4 will earn 75% scholarship on plus subscriptions, and 5 to 9 ranks will get 50, and 10 to 19 will get 25. See, human mind is such that everyone needs a motivation. We do need motivation, and we get in the form of salary. But when you have to study something as a student, you also need some motivation, right? So this is your motivation. You can earn your motivation this way. All right. So this is your chance to win really big. So if you happen to get the first rank and 100% scholarship, you will definitely get benefited, not just with your, savings, but also with the good education. And this is 3 plus 1, 12 plus 2, all these 2 months, 1 month free subscription. It's really worth it. So altogether you will get 4 months, and here you will get 14 months on the PG preparation. And then there is some new thing that has come up, subscription. You can go for 4 years instead of, renewing every now and then. You can go once for all 4 year subscription. If you happen to be in UG, I have one of the student, I think Faisal, you are in UG, right? Is Faisal in UG? Madhav, Country, Rohit, Megha, you're all welcome. So Faisal, I think he's in UG, if I'm not sure. If you're not, you shouldn't, feel bad, because I think I know you, Faisal. Yes, see. Yeah. So Faisal, you are in UG. So this is something that is nice for you, 4 year subscription. So you can go for such subscription where you can get the foundation itself neatly laid. Okay. So that way you can, are at a better chance to go for a good seat with the PG of your choice. What do you want to be? Which subject you like to be? Preclinical or clinical? Most of the people will aim for clinical only. So clinical, okay. So if you don't want to study from head to toe, okay, so ortho and radiology. So these two, if you take, you will have to study anatomy in and out. Okay. So this too will definitely demand so much of anatomy, because we have had so many students who have taken, planning to go for ortho and radio, and they have grabbed the seats also, and they are all the time with anatomy books. Okay, so this is INR 60 and INR 75 for iconic subscription. So iconic subscription will obviously have more things, and this you can avail at the earliest. Okay. So this is another feature, raise a hand, where you can raise your hand and ask questions. So this feature is there when you have your plus classes. You can watch out for this new icon, raise a hand. Okay, it's just like the hand itself, there is icon. And you need not carry your doubts to the next day. So there are some more things running parallelly, like the professional year first batch, that is 7th July. It just started. Then you have last mile to NEET PG, target next 2020. All these are some things that is like short duration courses, but it is really productive. So 2 months duration, 6 months duration. So this is for those who have already, read something and are looking out for some more motivation and some more things to grab. So you have lot of PDF notes and other material that you would be getting. So within 2 months, you will be in the last stretch, and you would be able to work on all your skills. Okay, so this is Focus FMG, that is also just started, and it is 6 months course with the top educators. Like we mentioned, all this comes with their PDF notes. Whatever is used for the class is also accessible. So it is interesting. So it's not that what you have, seen in the class that is lost. It is always there with all the highlights. So you would be having access all the time. You need not download and keep it anywhere. You have the access to Unacademy, and that way you also have access to anything that Unacademy offers. So 48 months here will have 1,125 rupees as EMI. So this is a EMI option, no cost EMI. With the minimum of 6 months subscription, you can go for this. Next, but don't forget to use the code ROHINI. So this is a code that you must use all the time when you want to access. So All this is from the Unacademy platform. And before we move on to the actual class with all the MCQs that I have lined up, and I would like to say a big thank you for listening, and don't forget the referral code. Okay, so this referral code is very important, and you want to save money as well as gain good knowledge, use the code. And don't forget to share, like, by visiting my profile. You can get more information about me, and also you have access to all the classes that I put up, and you will get notifications when you start following my profile. All right, let's start with the first one. Now, who can answer this? Have you heard of this? This is neuroanatomy. Identify the pathway. Anybody? Faisal also can answer because neuroanatomy is there for you also. So identify the pathway here. It is given, it is ascending auditory pathway. So what is the mnemonic that we can use here? We can use the mnemonic E. coli MA. Okay, you can use this. So now there is first order neuron, second order, and the third order neurons. So these are some of the neurons that, take this ascending sound waves towards the auditory area. Where is this auditory area? Anybody? What is the number? Anyone has an idea? What is the number? Richard? 44, 45. Yes, 44, 45. This is the auditory area. So you can see the first order, second order, and the third order neurons. Let me just give you a quick explanation on the same. I don't know if you have heard the flow chart. There are various ways to remember the things. One of the important ways is to remember it with the help of the flow chart. Now, how many of you know about the, I would just give neuron order here, and the ascending auditory pathway. You can just prompt me, and all right, the first one, first order neuron. Where is the first order neuron? Anybody? Where is the second order? First order neuron is which? In the inner ear, I know, but which neurons? They are all bipolar neurons. Okay, they're all bipolar neurons. That is something of the spiral ganglion. Spiral ganglion, bipolar neurons. So this is very important. You have to go to this depth. That is the first order. Second order neuron, anyone has an idea? Where is the second order neuron starting? Dorsal and ventral cochlear nuclei. There is also vestibular nuclei. This is cochlear nuclei, second order. What about the third order? Superior olivary complex. Superior olivary complex in the pons. So this is the third order neuron. And then there is this fourth order. Where is the fourth order? Anyone? Fourth order neurons. Anybody has an idea where it is? It is at the, that is fifth order. You have inferior colliculus. So remember the inferior colliculus, very, very important in the auditory pathway. You have to remember two things. One is the inferior colliculus, and the last order, that is the fifth order neurons. Fifth order neurons are at the medial geniculate body. Where is this? At thalamus. Okay, So medial geniculate body and the inferior colliculus, these two are very, very important. So you have to remember these two things. How do I remember? I would just remember M for middle ear, okay? So I would just remember M for middle ear. And who is confused? So many people are confused. Why? Why are you confused? So the fifth one. Okay, medial geniculate body. Is anyone confused now? How many neurons? See, there are so many. The pathway, if you see, you will know. See, there is the first starts with the cranial nerve here. You can see the dorsal cochlear nucleus, ventral cochlear nucleus, and then you can see the lateral lemniscus, the inferior colliculus. Then it ends at the medial geniculate body. Okay, M for music. Yes, M for music also you can remember. M for music. This is another one. You can see such things when you share, everybody can, also think of going with such mnemonic. So M for music, I would remember M for middle ear also. All right. So this is the last length, auditory cortex, 44, 45. And this is the mnemonic I would remember. All right. Okay. So these are the neurons, first order, second order. So here you must remember it starts with the bipolar spiral ganglion. Okay, bipolar. Where is unipolar? Any example do you know for unipolar? Unipolar? Think of this. Anybody? Where have you heard of unipolar neurons? Multipolar, we know. Dorsal root ganglion, yes. Dorsal root is unipolar. So similarly like this, whenever you come across some word that is interesting, you should also look for, the other kind, similar things in the same group. Like bipolar, you should have an example. Unipolar, you should have an example. Multipolar, we all know. It's very easy to remember. But unipolar, bipolar, probably suddenly you will not be able to think. That's why. So this is an important one, auditory pathway. Don't ever forget. M for music, like Debian suggested, right? Next one. Okay, now lesions of the cochlear division results in. Now, who can answer this question? What does it result in? Cochlear division. Have you heard of lesions of cochlear division? What does it result in? So here you have to think of what are the lesions that we can list. Results in. Have you heard of tinnitus? Okay, so this is the deafness, like he mentioned, sensory neural deafness may or may not be accompanied by the tinnitus. Okay, now differential diagnosis between the middle ear deafness and the cochlear deafness, it's very, very important. So now here clinically by use of a tuning fork, you can differentiate both of them. And air conduction, that is fork being held beside the ear, it is normally louder than the bone conduction, right? So now the fork being held against the mastoid process. So which one, I'm sure you must have done all these during your clinical rounds. You must have tried all this. If the middle ear is damaged, reverse will hold true. So you have to remember which one is louder, which one is air conduction deafness, and which one is bone conduction deafness, and where you are supposed to hold the tuning fork, you must know. And if the middle ear is damaged, then opposite will be, in the sense if it is heard louder. So this, you know that air conduction is normally louder, that will not be heard louder if there is middle ear damage. As simple as that. All right, next. We'll go to little more explanation on the same. Now, I told you about the tinnitus, right? What is tinnitus? There are two types. Anyone knows what are the two types you can think of? Rini and Weber's test. Yes, we can talk lots and lots about tinnitus, but there is something called subjective tinnitus and objective. And subjective tinnitus, what happens to the patient? Patient will hear what kind of sound he perceives. Right? Only patient will perceive the head noise. Then there is another point in the subjective. That's why subjective. Okay, the subject is the patient. And next one, this is common. Where it is common? Is the most common. You get a lot of patients with subjective tinnitus. Okay, these could be various reasons, like, for tinnitus, there could be various reasons, like the hallucinations. And in many diseases, you will see those auditory hallucinations. And there is one more thing called auditory tinnitus. Any particular thing you want to add in auditory hallucinations and objective tinnitus? Anybody? Rohit, Debyan? Anything more you have heard of? What is objective? What is the difference between subjective and objective is what I'm asking. Here, head noise. Is it only the patient who can hear? Head noise is audible to patient plus the doctor, both of them. Okay, that's why objective. Next, what we can add? What points we can add? So it starts here, you can hear, and then there is head, neck region, and muscular and vascular etiology you can see. And then what else we can add? We can also add that myoclonus. So this is one of the feature of objective tinnitus. So you keep this in mind in any kind of degenerative diseases. This is one of the important sign you can identify, myoclonus. Okay, so that is the difference between subjective tinnitus and objective. All right, next one. The tumors of which lobe gives rise to auditory hallucinations? So this is another one with the same kind of topic here. So now, which tumors, where should the tumor be to give rise to auditory hallucinations? Temporal. So because the area 44 and 45 is what we were talking about. And see here, primary psychotic disorders, human voices, noises, all these commands that come from outside. So all this, both intoxication. So people who are completely alcoholic, they can also hear some commands from outside. And it could also be due to withdrawal symptoms. Withdrawal symptoms also can show some auditory hallucinations. All types of voices and noises are heard. So now here there is another reason, that is the cranial nerve 7 tumors, okay, which press upon these nerves can also cause tinnitus. This is one of the reasons for tinnitus. And they could hear all these vague noises. Then they could also hear some music which is not being played. And they are perceived as coming from within, okay. There is epilepsy, brain neoplasms. All these are some of the causes of auditory hallucination. So you must remember delirium, dementia, all these are again some of the causes for auditory hallucination. So you should keep in mind what are the causes. So when you cannot just go with one thing that you have in mind, right? There could be many other options other than what exactly you have studied or you have come across or seen. So this is auditory hallucination. So this is another one. Okay, so this is the auditory center. All this time we have been talking about temporal area. So this is the one. All right, now decreased activation left superior temporal gyrus negatively affects the reading skills. Did you know this? Okay, so these children with poor reading ability skills are all said to have the, deactivation, so decreased activation or deactivation along the left superior temporal gyrus. So this is something you just keep in mind. There could be a scenario question. Okay. Next, inflammation of the parietal pleura. Now we are coming to the thorax now. Some questions from thorax. This is inflammation of parietal pleura mimics abdominal emergency. Why? Anybody? Pleura is supplied by what? First of all, what is the supply for pleura? Nerve supply. So it results in a lot of abdominal pain. But why parietal pleura? Phrenic supplies the pleura, pericardium, and the diaphragm. Keep that in mind. Okay, so I would just remember like PP, D. You add one more P if you want to remember the phrenic also. So that is 3PD. This is the explanation I would suggest. Parietal pleura is segmentally innervated by intercostal nerves. Now, it is innervated by the intercostal nerves, and inflammation of the pleura always results in referred pain along the cutaneous distribution of these nerves. So that is to the thoracic wall, or in the lower case, nerves of the lower intercostal areas. It could be in the anterior abdominal wall also. So this is the reason the inflammation actually mimics the emergency case for abdominal pain. So it could also mimic, kind of pain that the patient experienced during when he has this pain during the kidney stone or pancreatitis, etc. So it could be misleading, and it may mimic a acute abdominal emergency. So keep that in mind. It is innervated by intercostal nerves, and it runs along the distribution of these nerves. So that is one thing to note. So the pain also will be in the area only. Okay, next one. To drain the fluid from the pleural cavity, so you have to know what is the extension of pleura. Okay, you know that the lungs are covered by the parietal and the visceral. So pleural cavity is between them, and which intercostal space is chosen? Any idea? Is it that low? Is it 9th to 10th? Is it that low, Rohit? I would go with Debian. So fluid can be drained from the pleural cavity by inserting the needle. So again, it depends. No, there are many people who would go with that also, but usually it is 7th intercostal space posteriorly. So now needle is passed along the superior border of the lower lip, so that, avoid the intercostal nerves and vessels. So you should know exactly where the intercostal nerves and vessels are, and only then, without damaging them, you should be accessing the space, and then only you can drain. So this is this, usually chosen one is 7th posterior. So remember this posterior also, Debian. If you know only 7th posterior also, you add to your brain and remember that. So now below the 7th intercostal space, there is danger of penetrating the diaphragm. That's the reason. All right. So it again depends on the choice. So 9th and 10th, I'm not saying it's wrong, but there is always a danger. You want to avoid the danger, you go with the 7th, which is the safest. Next, trachea. Trachea commences from, what is the point at where it starts? Trachea bifurcates. Trachea bifurcates at what level? At the level of T4, T5. Sternal angle, right? Angle of Lewis. So obviously trachea commences above that. So that's a common sense. So you should now think now. Definitely it is not below the T4, right? So where does it start? Bifurcation is at T4. So obviously it would have started much higher. So now let's see, use some common sense and then let's see. Now here, trachea is about 11.5 centimeters and nearly about 2.5 centimeters in diameter, and then it commences at the lower border of the C6 itself. So it is not even thoracic, it is at the level of C6. Okay, C6 has one tubercle. Have you heard of the tubercle? What is the tubercle name? C6 has a tubercle also. Carotid tubercle. Yes. So like that, you have to relate things. When you hear something about this, like now we heard C6. Now you can think of any one important thing about C6 so that you can relate things. Always you should relate things, and that way you can retain more things. By just one reading, you can retain many things. That is the idea. So NEET preparation is completely different from how you study for your UG. So UG, you need lot of reading like newspaper. You go on reading. And here NEET, everything is not important. You have to go with the keywords to retain. Those keywords should give you, if there is one keyword that should be answering 4 or 5 questions in your head. That's how it should be. Okay, so remember the sternal angle of Lewis, that is T4, T5, that is where it bifurcates. So it starts much before, that is C6. Okay, at the level of cricoid cartilage. Which border? Lower border of cricoid cartilage. Next, what accounts for the greater tendency of foreign body and aspirated material to pass into right bronchi? So there is right and left. We just saw that it divides at the level of sternal, but right one and left one. So which one is shorter? Which one is narrower and straight course? Which one does not have an angle? Think of, yes. So the straight and short is the right one. So obviously many children, we have seen that they ingest these small coins or some kind of button like things, and it could right away land in the right bronchi most of the time. So that is the greater width, that is one thing, and vertical course of the right bronchus is what accounts for the tendency of foreign body to be aspirated into. All right. So that is one thing rather than the left one. So, but which lobe? See, especially into which lobe? Middle and lower lobes of the right. Middle and lower lobes. So, it does not go to the upper lobe because that opening is below the upper lobe. So, obviously, it will go to the lower ones. So, it will land here. So now here, one more thing I want to mention is anything that you know about right and left lung difference. What are the structures at the hilum? Structures at the hilum, if you discuss right side, everything is more, okay? There is eparterial, hyparterial, bronchi. Here there is only one. Here there is two. And the number of fissures, how many fissures? 2 fissures. So 3 lobes. Here only one fissure. 2 lobes. Left is everything is less. All right. So remember left side, everything is one less. All right. Next one. Okay. This is the question that was just a slide which did not have the question. So brachial plexus has, this is from the upper limb. Now we have moved from the neuroanatomy to thorax. Now I'm taking you to upper limb. So first of all, you should learn to identify from which section it is. That is also important, right? You can't simply have everything in your head and start thinking from randomly. So first you have to narrow down. So now you think only about the upper limb section and you start with this one. Brachial plexus has, now looks like everyone is counting now. How many things? Is it 8 rami, 5 trunks, 6 divisions, 4 cords? Many of you think 6 divisions? None of the above. So let's see whether Rohit is correct. C. Yes, Rohit is correct. It is divisions, right? So this is what we have. We have the C5, 6, 7, C8 and T1. And these are the trunks. So now I would just remember this as, are you tired? Okay, drink coffee, buddy. So this is the order in which I would go. And just remember it like a phone number actually. Try to remember this like a phone number. So that will help you recall it really quick. Rohit did. How did you do? 5 roots, 3 trunks, 5 divisions. Okay. So this is how you remember. There is anterior division, posterior division. So each one has 2 divisions. So that way the 6 is correct. So we have got the easiest one as the answer to pick. So it was easy. And if they had given branches, it would have been even more difficult because branches, there are so many, it is difficult to count. So lateral, now tell me one quickly, what is the root value of radial? Quickly, who can tell me? Root value of radial. All roots. Median? Median? Root value? Same. Okay. Next, what about the musculocutaneous? The first 3, you remember? The first 3, that is C5, C6, C7. Right? Ulnar, last 2. C8, T1. And axillary, the first 2, C5, C6. Now, which one is associated with the Erb's palsy? Which one is associated with the Erb's? Which nerve is damaged in Erb's palsy? Okay. Which one is completely not affected in Erb's palsy? Which one is completely unaffected? Nothing happens to those from that particular root. Ulnar. So Erb's, this is completely spared. Okay. So axillary is completely damaged. So you think of axillary, first of all, completely damaged. So you put, first thing you put is deltoid. So deltoid and teres minor. So obviously the person will have absolutely no abduction. So no abduction is the main feature of Erb's palsy. Okay. The patient will show absolutely no abduction because axillary is damaged. That is important. Clump case, how would you remember? I have a nice, monkey song. Clump case monkey. clumsy monkey was hanging from lower trunk of tree or brachial plexus. So it is lower trunk and hanging. Remember hanging. So which nerve is damaged? C8 and T1 because it is from the inferior. Because it is from the inferior trunk or the lower trunk. So that's why the name, the lower, okay? That's why the name lower. So it is from the lower trunk I have used here. And I said clumsy monkey. So immediately you should know which trunk is damaged, okay? Lower trunk. In herbs, it is which trunk? The upper trunk. So all combinations, you should just put it like this and study. Otherwise, it becomes difficult. You should make it very interesting always. Next one. Okay, now who can tell me this? The persistent distal part of sixth arch on the left side is also known as, what is it known as? What is it known as? Which nerve is related to this? See, you should remember the recurrent laryngeal nerve. Recurrent laryngeal nerve is related to aortic arches. So this is the big, huge explanation, but this is a very important question. So we have to give some, minutes to read this because it is very, very important. Many a times it's been asked. Now, there is asymmetrical development of aortic arches, which accounts for the different course that is taken by recurrent laryngeal nerve, right? So on each side, the right side it is different, left side it is different. But in the early fetus, what happens is the vagus nerve lies lateral to primitive pharynx and it is separated by the aortic arches. Later, what recurrent laryngeal nerve passes medially, caudal to the aortic arches. What it supplies? It supplies the structures at the larynx. Now, with elongation of the neck as the person grows or the fetus grows, with the elongation of the neck and caudal migration of the heart, what happens to recurrent laryngeal nerves are caught up and dragged. You can see that it is now, see, this is how it is dragged. You can see that how it is dragged. All right, see here. Look at the recurrent laryngeal nerve here on this side, right side, and on the left side. Which one is higher? Which one is lower? Which one is higher? Which one is lower? The right side is this one. The left side is this one. All right, this is right and this is left. So don't worry about the question. Question is just framed. On the sixth arch, the persistent distal part of the sixth arch on the left side is also known as this one. What is it also known as? Have you heard of this? The ductus arteriosus. That is what is the answer. But the thing is, you should know, see, where is the level of the recurrent laryngeal nerve? Where is the level of the recurrent laryngeal nerve? On the left side and on the right side. All right, so this is ductus arteriosus. So because arch of aorta is formed on the left. So that's why the recurrent laryngeal nerve is pushed downwards. And this is at a higher level on the right side and it is at a lower level on the left side. So this is what you must know. That's all. So here it is at the level of 4 and this is at the level of 6th. Okay, so you can just read up this. So this is at the level of 6th and that is where you have this ligamentum arteriosum, which was, actually a patent ductus arteriosus. So it is dwarfed by the arch of aorta. So that is what you are supposed to keep in mind. The other theory part is not important, but you should remember on the left side where exactly it is, on the right side where exactly it is. The ductus arteriosus, which is now known as ligamentum arteriosus in adult, is at the level of sixth arch. So on the left side it is sixth, and on the right side it is fourth. All right. So that's the level of recurrent laryngeal nerve. Next, what is this one? Anybody? Elbow. Look at the elbow. What has happened to the elbow? It is dislocated. Do you think it is dislocated? Don't you think it is inflammation, bursitis? Now, inflammation of the subcutaneous olecranon, that's what you can see. See, it is a triangular area that is on the dorsal surface of the olecranon process of the ulna. So, olecranon process of the ulnar head actually, gives attachment to the triceps. So, to protect these muscles, triceps, you have bursa. So inflammation of that bursa is what resulted in olecranon bursitis. So you should remember to protect which muscle tendon you have this bursa. It is triceps. Triceps attachment is on the long head. So students usually they cannot, stretch their hands, or they will have problem, or they will face pain on the backside of the arm once it is kept on the table for a longer time. That is because of the pressure on the bursa that protects the tendons of triceps. All right. So that occurs due to repeated friction that occurs. Students who sit and read for long hours like you, and you put your elbow on the table, and the table could be rough and hard, and that can result in bursitis. So next one, what is this? What has happened to the wrist? There is no extension. There is no extension, right? So what has happened? It is dropped. So wrist drop happens due to radial nerve damage. Where? Where does it get damaged? Is it at the axilla, or is it at the spiral groove, or is it where? In the forearm, the radial nerve passes between which muscle? The fibers of which muscle? In the spiral groove, yes. In the spiral groove, when it is damaged, that is where, the forearm muscles will not be, not pronator teres, dear, it is the supinator. Supinator is the extensor muscle. Pronator teres is flexor muscle. Nothing passes between the pronator teres fibers. It is the extensor muscle, supinator. So when you do the cubital fossa, study, you can know that the boundaries of the cubital fossa, medially there is pronator teres, laterally there is brachioradialis. Okay. Laterally, brachioradialis, this is medially pronator teres. But the floor is formed by supinator. Obviously, you are hitting the bone, olecranon and the supinator. So these two are the floor. So that, what does that indicate? It indicates that it is on the other side, on the extensor compartment. Cubital fossa is in the front portion of your elbow. All right. So damage to radial nerve in the spiral groove, what causes this condition, wrist drop. So now here patient is trying to do some action. What is the action that he is unable to do? He is trying, but his face itself shows that he is struggling. What is that action? Shoulder abduction. So probably he must have helped to, Yeah, it could be even 90 degree. I don't think he is able to do. Forget about the overhead abduction. Is it overhead? Even 90 degree, is he not struggling? See, it is not even 90. Okay, so you should know 0 to 15 is done by which one, 15 to 90 is done by which one, and 90 to 120 by which one. What is this one? Supraspinatus. Yes, this is deltoid, and this one is serratus anterior, right? Now, we have to see which one is this one. It is ruptured supraspinatus. So the patient, no trapezius, it is supraspinatus, and supraspinatus can get ruptured because it is in a very dangerous spot. Actually, you can see it is this supraspinatus is above the spine. This is a muscle, and it is so much close to the glenohumeral joint, shoulder joint, as well as the acromioclavicular joint. So any fracture around this area can damage the supraspinatus. And also it is very vulnerable to injury with the moving joint. Plus also the tendon itself could, tear because of some jerky movements. So 0 to 15 degree abduction, he's struggling. But how do you think he managed to lift so much? Probably he had support from the other hand. He must have pushed his arm and he was able to do 0 to 15. So you have to see whether he is able to do 15 to 90. If he is not able to do, that means this was assisted. This he did because of the assistance from the opposite side. All right. Unassisted, if he is able to do, then it's a different story. All right. If there is no axillary nerve injury, then there is no way the deltoid could damage, right, easily. So it is supraspinatus because deltoid is nowhere close to the joint. The one which is close to the joint is which one? The supraspinatus. That we can detect only with the help of the X-ray. All right, that is supraspinatus. Sensory intact in spiral groove injury. Sensory is not intact. Yes, it is intact because it gives that branch later. So there is the superficial and deep branch. All right, there is superficial. Superficial is given when it passes between the heads of the supinator. So it is not intact. Okay, it has already crossed the spiral groove, so it is not intact. So both the sensory as well as the motor is not intact. All right, next one. Lady delivered a baby after she was assisted forceps method delivery, and where the gynec had to pull the baby's hand using forceps. Okay, this is what was done. So baby's hand was pulled. Hanging from the lower trunk is different. Only when the head is stuck inside the birth canal and only the shoulder is pulled using baby's hand. It results in what? Upper trunk near the neck, it gets stretched, upper portion of the neck, then it is upper trunk is what is disturbed, and that results in Erb's palsy. So here the baby's arm is medially rotated. Okay, it is not abducted. Is it abducted? See, we should always find a fault in the question itself. It is not abducted, it should be adducted. So when you find fault in the question itself, then you know you have studied. Adducted. So immediately we should clarify. It is adducted and forearm was extended. That is correct. And also pronated, correct. Everything is correct except for this. Okay. So let's see. This is the Erb's palsy. You can see the elbow extended, forearm pronated. Look at the hand. It is also known as weighted stiff hand. Okay, so that is one thing. Last one, weighted stiff hand. Okay, so the last one, I would end with big thank you, and I would like to thank all those who participated. Everything was really beautiful. So do join in for more classes every single morning. I have it. You will get a notification once you start following me on my profile. You would be getting the notifications. So do follow. And always, I would suggest the mixed MCQs are best. Okay, so that will help you. You would be doing the chapter wise, but always try the mixed MCQs. If you have finished reading, then mixed MCQs you always try, because you will be thinking in from all directions. So your thinking will be faster. That you should learn. All right. So look out for my other classes at 10 p.m. I have 10 p.m. class every single day. That is again some topic and picture-based, image-based discussion. So that's also very interesting. So join for that. And also have 8 a.m. class. And I also have some vertical integration classes coming up this month end with the ortho and radiology. So I'll be doing some image-based, discussions, and also bone and related stuff. Okay, to help with the ortho and radiology studies. All right, so all this is going to come up in the end of this month. And before that, I have currently running the classes for the first year professionals. Okay, right now we are talking about the practical and Viva VOC topics. So Faisal, I think I met you there. So practical and Viva VOC is what we discuss in those classes. That is there every weekend. So every weekend there is something nice. So don't forget this 10 p.m. If you are interested in MCQs and such discussions, you should join this. All right, this is on YouTube, and this is on the Plus classes, and this 8 a.m. is special. Yes, 10 p.m. is on YouTube. Okay, myself, if you don't remember my name now, so this is my name, so Rohini. Look for this name, you will see all my classes. Thank you so much, guys. Thank you all. You have a good day. Bye.